Today we will talk about the principles, skills required for the examination of the precordium. Really, prior to that, as always in medicine, when we want to examine the precordium or any part of the body, we have to take a permission from the patient for such an examination, as I'll show it now. السلام عليكم. استسمح لنا محمد اليوم نفحصك نفحص صدرك. Examination of the precordium, really. Let's first know what is meant by the precordium. Precordium refers to the anterior part of the chest that overlies the heart. So, if the order of examination is to examine the precordium, this really does mean examination of the heart. Examination of the heart is a systemic examination like the abdomen, like the respiratory system, consists of inspection, palpation, auscultation, and rarely percussion is performed for the precordium. As we will see now, first of all we have to elevate the head of the bed for 45 degrees, and we will perform these three steps, as I said, the inspection, palpation, and the auscultation. First of all, I will stand at the end of the bed and looking at the chest to see, first of all, whether it is a normal of a normal shape or not. Really, what is meant by normal shape of the chest? Normal shape of the chest, just like this chest is a normal in shape. Normal shape means that the chest is symmetrical in shape. This is one. Second, elliptical in a cross section, and the transverse diameter more than the antero-posterior diameter at a ratio of 7 to 5 cm. That's to say, each 7 cm in the transverse diameter correspond to 5 cm from the AP diameter. In addition to that, there must be no any deviation or bending, either laterally or forward. There must be no. If all these parameters being present in a chest, we can call this chest or we can label it as a normal shape of the chest. What is the abnormality involving the shape of the chest? One of them may have scoliosis, that's to say we have a lateral bending. Second one is the kyphosis, that's to say forward bending. These two abnormalities are important because both of them may alter the position of the cardiac impulse. Second, may result in heart failure. Okay, other abnormal shape may include sternal depression, that's to say there is a depression here at the lower end of the sternum. Also, this results in deviation of the cardiac impulse, or what we call it pictus carinatum or pigeon chest. That's to say there is a prominence here involving the sternum and the costal cartilage here. Also, this will result in displacement of the cardiac impulse. Last one is what we call it the barrel chest. That's to say the antero-posterior diameter is more than the transverse diameter or even equal to the transverse diameter. It's considered as abnormal. This is really regarding the shape of the chest. So I had seen it from the end of the bed and now across the chest of the patient to see the antero-posterior diameter. This is just one point in the inspection. The second point, I have to look whether the patient had a scar. Really not any scar, but a scar that is peculiar to the cardiovascular system. This scar may include, first of all, median sternotomy scar. Here, just here, it extends from the upper up to the lower part of the sternum. This is really used in open heart surgery for pacement, whether mitral or aortic. It also can be used in CABG surgery. Okay, here. And an important point I would like to just tell you about it is in male patient, really there may be heavy or presence of forest of hair on the chest, so we have to displace the hair laterally and to see whether there is a scar underlying it or not. This is the first one. Second scar we have to look at is the lateral thoracotomy scar or left submammary scar extending from here down up to the back of the patient. That really this scar is the result of an operation that is used for closed mitral valvotomy. Also an important point here is in female now, sometimes the pendulous breast overlie it, so you have to displace the breast slightly upward and laterally to look for this scar specifically. Last scar, which is also important to look for in the examination of the chest, is infraclavicular scar, either here or either here, left or right. This scar really is the result of an operation for pacemaker or cardioverter defibrillator boxes, either here or either here. Okay, this is just about the inspection for the chest. Other point important in the inspection of the chest is the presence of visible pulsation. This is the third point. What is important to look at in the chest for visible pulsation? Really, you have to look at the following points. First of all, you have to look here, just at the mitral area. If there is any visible pulsation, sometimes the cardiac impulse is visible. Okay, due to, for example, hypertrophic cardiomyopathy or in patient with hypertension. Second one is to look at the left parasternal edge here for RVH. Right ventricular hypertrophy will result in visible pulsation here. Third pulsation we have to look at is here at the pulmonary area, if there is pulmonary hypertension. Other is suprasternal notch. Pulsation here may indicate the aortic arch aneurysm. Other pulsation is carotid, either here or here. If there is huge and enormous pulsation here, what we call it carotid shudder or Corrigan sign, that occur in patient with hyperdynamic circulation, especially in patient with aortic regurgitation. In addition, you have to look for the jugular veins, whether they are distended or not. Other visible pulsation you have to look at is the upper right parasternal area here for ascending aortic aneurysm. And lastly, you have to look at the epigastrium when we ask the patient to hold his breath, just like me when I ask the patient now. Okay, if we see here, just focus on this area. أخذ نفس. هسه اقطع. Okay, we can see. Okay, we can see. We can see now visible pulsation here. This may normally occur in thin individual and in normal persons, but abnormally may occur in abdominal aortic aneurysm, or in patient with tricuspid regurgitation due to pulsatile liver, and sometimes in patient with right ventricular hypertrophy. This is all about the inspection. The next step of the precordium examination is the palpation. Palpation, the patient also in 45 degree, the head of the bed being elevated, and we have to look at the following points. First of all, I have to know where is the cardiac impulse is. That's to say the localization of the cardiac impulse. Second one, I have to characterize the cardiac impulse. What is the character of the cardiac impulse? And the third one, I have to look for thrill, lifts, that's to say heel, and for palpable heart sound. Now we will demonstrate all these points in this scene. Okay, I have first of all to localize the apex beat. How I can localize the apex beat? I'll screen a wide area. Okay, I put my hand over the nipple and slightly lower, and then extending it up to the axillary area with my palmar surface of my hands. Looking for what? Really looking for cardiac impulse or apex speed. What is apex speed? Apex speed is the palpable, gentle, brief impulse that is lateral most, lower most, that can slightly lift the finger, overlies it. This is the definition of the apex speed, so I have to localize it well. Okay, I can now detect the apex speed now here, but let's suppose that I failed in the detection. Normally 50% of the individuals, they have impalpable apex speed, which is normally. So what is the next step I have to perform? The next step is to turn the patient to the left side. Okay, by this maneuver we can really detect the apex speed. Okay. I ask the patient to turn himself into the lateral position because the cardiac apex became more close, more proximal to the anterior chest. Okay, if I had detected the apex speed here, I have to give a character for it. That's to say, I have to characterize the apex speed by the tips of my finger, and I have to give a character for it. Then when I localize it, I keep it in my mind, this position. Then I'll count the apex speed and decide whether it is displaced or not. This is the sternal angle, slightly below it. This is the suprasternal node, sorry. Slightly below it is this is the sternal angle, correspond to the second rib. This is second intercostal space, third, fourth, and this is the fifth intercostal space. This is whether or not the apex speed or cardiac impulse is displaced downward or not. Then I have to look by an imaginary line for the clavicle, an imaginary line that bisect the clavicle, what we call it the left interclavicular line, and to look for whether, by which we can decide whether the apex speed is at this line, beyond it, lateral to it, that's to say displaced laterally or medially. The normal apex speed, the normal cardiac impulse is normally at the or slightly medial to the left interclavicular line. Okay, at the fifth intercostal space also we have discovered now that it is at the fifth intercostal space. Okay, this is the cardiac impulse I had detected and give it a character for. Abnormal character may take the form of tapping apex speed that occur in MS. Other abnormality that may characterize the apex speed, or maybe a feature for apex speed, is the pressure loaded, what we call it heaving apex speeds. That's to say forceful, sustained, but undisplaced apex speed, which is a character of pressure overload in case of hypertension or aortic stenosis. Other character for the apex speed is the volume loaded apex speed, which occur in volume overload in case of aortic regurgitation and in mitral regurgitation. This character or this feature differs from the pressure loaded apex speed in that it is displaced, unlike the case of a pressure loaded. That's to say, pressure loaded apex speed is not displaced while volume loaded is displaced. Other character is the double apex speed. When we have double impulse here, this is a feature of hypertrophic cardiomyopathy. The last feature for cardiac impulse is what we call it dyskinetic cardiac impulse, which occur in for example in heart failure. Okay, after that I have to look for the thrill, heave or lifts, and for palpable heart sound. As I said, palpable heart sound should not be normally palpable. Any palpable sound is abnormal. How I can do that? Really in the following maneuver. First of all, I'll put my finger here, looking for the palpable first heart sound, or palpable third heart sound, or palpable fourth heart sound. Then I'll use this part of my hand, which is the metacarpal heads, also over this area in such a manner. This is to detect the thrill. Really, here we can feel the thrill, diastolic thrill of mitral stenosis. And then I'll look for lift in such a maneuver. I'll use the base of my palm in such a maneuver, and 90 degree, my elbow is flexed to 90 degree, and I'll look at my elbow junction, at my elbow joint. Okay, if there is a lift, I'll see my hand like this. This indicates a lift. The lift here, or the heave here, we call it the apical heave, which typified LVH. Then I'll go to the left parasternal area. Here I'll put also this part, looking for the thrill. Then I'll look for heave. Then I'll put also this part to look for the thrill for VSD. This area we call it Erb's area. Then I'll put my finger again to look for palpable P2, and looking for a thrill. There is no other heave, just these two sides. And then at the aortic area, I'll look for systolic thrill of aortic stenosis. Okay, after that I have to look for a thrill of mitral stenosis in such a manner. I'll put it over the mitral area. استقدر تندار. Then I'll ask the patient to turn himself. Okay, then I'll ask the patient to sit. بس تسمح لنا تقعد حمادة. I'll put also the palmar, this part of my palmar surface, over the pulmonary area and over the aortic area, and asking the patient to exhale breathing. حمادة تاخذ نفس والذبة وطلع من صدرك. بعد ما تاخذ نفس نفسي أنا شوف هسه أنا وقتها اقطع. Okay, this is really about the palpation. Really, the palpation follows what we call the Z cycle or Z rule, starting from the mitral area. This is the mitral area, and then for the tricuspid area or left parasternal area, and then into Erb's area for VSD, and then into pulmonary area, and then into the aortic area. This is about the palpation. What is meant by thrill? What is meant by heave? What is meant by palpable sound? Palpable sound, really, the sound, as I said, should not be normally palpable. When it's palpable, it indicates underlying pathology. For example, palpable S1 occur in mitral stenosis. Palpable P2 occur in patient with pulmonary hypertension. Palpable S3 may occur in patient with constrictive pericarditis, and palpable S4 may occur in patient with hypertrophic cardiomyopathy. Third heart sound, fourth heart sound, left ventricular, and first heart sound are best to be detected at the mitral area, while second heart sound, pulmonary component, is better to be detected at the pulmonary area. What is meant by heave? And what is meant by thrill? A thrill is a superficial sensation of vibration. It looks like a vibrating telephone, mobile telephone, just like this sensation will give you. This indicates that there is underlying murmur, and also it could be systolic thrill and diastolic thrill. Heave or lift is a palpable impulse that is noticeably elevate or lift the hand. And for this reason we use this maneuver to detect it. This one, the apical heave, and here is the left parasternal heave. This indicates RVH and this indicates LVH. Okay, this is about the palpation. The last step in the precordial examination is the auscultation of the patient. Really, prior to performing an auscultation,